Good morning. My name is Cristo Luna. I'm the Health Graduate Fellow for CHCI. I'm delighted to be here today for the Return to Care, COVID-19's lasting impact on our health session. A little background about myself. I was a care coordinator in the emergency department starting in 2020 of the pandemic. So I saw firsthand the social determinants of health that our community was going through, especially during the pandemic. So I'm honored to be here today. So Representative Stephen Horsford is actually running a little late. So I'm gonna give your bio, introduce him, and he'll be here in a little bit. So Representative Horsford represents Nevada's 4th Congressional District. He sits on 3 congressional committees: the House of Ways and Means Committee, the Budget Committee, and the Armed Services Committee. Representative Horsford co-leads the House Ways and Means Committee Racial Equity Initiative, which works to address the role of racism and other forms of discrimination and perpetuating health and economic inequalities. And he will be here momentarily. All righty, and without further ado, let's see. Our sponsor speaker, Juan Carlos Scott, President and CEO of Pharmaceutical Care Management Association. It is now my pleasure to introduce JC. So JC is the President and CEO of Pharmaceutical Care Management Association, the national association representing America's Pharmacy Benefits Managers, or PBMs. Previously, JC held senior association leadership positions at Washington-based organizations and served in various capacities in the U.S. House of Representatives, including as Deputy Director of Policy for the House Republican Conference. Sponsor speaker Juan Carlos Scott.
Good morning. Thank you for the kind introduction. I recognize I'm not the member of Congress you were hoping to hear from first, but I will fill some time. As was said, I'm Juan Carlos Scott. I'm with PCMA, and we are the association representing pharmacy benefit managers, but this morning I'm representing one of our leading member companies, Elevance Health. Elevance Health insures 47 million consumers through their commercial, Medicaid, and Medicare lines of business and has close to 100,000 employees. And if you've never heard of Elevance, that's okay. You actually know them. Elevance is the new name for Anthem, which they announced on June 28th. Same great company doing work on behalf of patients, including through their own PBM, IngenioRx, where they focused on delivering affordability and quality for patients' prescription drug needs. Like all PBMs, Ingenio does that work on behalf of both patients and the employers and others who sponsor health insurance. PBMs save payers like employers up to 50% on their employees' drug costs, which helps them to offer competitive wages and retirement benefits, which is part of the reason nominal hourly wages are up nearly double what they were before the pandemic. This morning's panel will be talking about the importance of healthcare access for the Latino community, especially coming out of the pandemic. And there are 2 sides of the coin when it comes to access to pharmaceuticals and medications. We have to ensure the innovation coming out of the pharma community to ensure that next generation of treatments and cures, and we have to promote affordability, because without affordability and lower cost, there is no true access. And that affordability challenge can be especially acute in some of our Latino communities. PBMs support both sides of that coin, with our work focused in particular on promoting affordable medication access for all communities. During the early days of the pandemic, in particular, that mission was all the more important. PBMs stepped up to promote vaccinations through local and national outreach campaigns, to leverage their home delivery capabilities to help many patients maintain safe and predictable access in their homes, and to partner with others in the manufacturing and pharmacy communities to watch for drug shortages, help maintain access to medications that were in demand as both COVID treatments as well as for other patient groups, things like asthma patients who need steady access to albuterol for their inhalers. PBMs and the entire prescription drug supply chain have done important work during the pandemic and can be essential partners as we consider how we address the lasting impact of the pandemic on the health of our Latino communities. I look forward to hearing the panel discussion, and on behalf of Elevance Health, thank you for the opportunity to join you this morning.
All righty. Thank you, JC. It is now my pleasure to introduce today's moderator, Sarah Dash. Sarah is the President and Chief Executive Officer at the Alliance for Health Policy. She has long been an influential force in shaping health policy, having served as a senior aide on Capitol Hill and as a member of research faculty at Georgetown University Health Policy Institute's Center on Health Insurance Reform. Please welcome Sarah Dash.
Thank you. Thank you so much, Christos. And good morning, everybody. It's so great to be here. The last time that I was supposed to moderate a panel for the Congressional Hispanic Caucus Institute, I found out at like 2 o'clock in the morning that I had COVID and everyone had to scramble. So I am so happy to be here. I want to ask before we get started, because this is going to be a fabulous panel, how many people in the audience feel like your routines are back to normal? 1, 2, kind of, 3. Yeah. How many feel like your routines are like still settling back in? Yeah, like most of us. Yeah. How many feel like it's back to better? 1 person a little better. Okay. So like, let's acknowledge we're all still in a little bit of a state of flux, maybe, that's fair to say. And so it's really great to be here today to talk about this concept of return to care, as we return from the pandemic, if you will, in sort of fits and starts as we emerge back, into whatever the new reality is. I'm really looking forward to this conversation with 4 really incredibly deep experts about what lessons, both good and bad, we've learned about healthcare delivery and how we can apply these lessons not only to improve the quality of healthcare and access to care in the future, but also to really finally get to a place where we can have meaningful movement forward on addressing health equity and health disparities as well. So I'm really delighted to be joined by 4 experts, and I'll introduce them now. Please welcome Dr. Alicia Zoo. Alicia is Color's Chief Science Officer, leading their research, scientific, and medical affairs teams. She's responsible for managing research collaborations with academic institutions, biopharmaceutical companies, and large population initiatives, as well as initiating, executing, and publishing peer-reviewed manuscripts and research by Color's scientists and engineers. Welcome, Alicia.
Thank you.
Hey, great. And next to Alicia, we have Dr. Veronica Sandoval. Veronica is a principal in the Patient Inclusion and Health Equity team in the Chief Diversity Office at Genentech. And Veronica's policy and medical background, along with her personal and professional intersection of her Latina and health equity efforts, really bring a rich perspective to Genentech's ongoing work in health equity and inclusive research. Welcome. Yeah. You know what? They get a round of applause because I think almost everyone on this panel came from California, right?
In a way.
Like, I mean, I could barely get here from Silver Spring, so shout out to y'all. Okay, and next we welcome Dr. Ahmed Sharma. I did it wrong. Amit.
It's good.
Dr. Ahmed Sharma. Okay, Amit is the Vice President of U.S. Medical Affairs in the Cardiovascular and Renal Division for Bayer U.S. Pharmaceuticals. He is board certified in internal medicine, nephrology, and has an additional certification as a hypertension specialist. He currently serves on the board of directors for the Kidney Health Initiative. And finally, please welcome Dr. Richard Raposa. Richard is Divisional Vice President of Global Product Development for Abbott's vascular business in Santa Clara, California. He has more than 30 years of experience in the cardiovascular field with expertise in biomaterials research engineering, development engineering, marketing, quality manufacturing, and innovative product development. And participants, please feel free to tweet your comments or questions about this session, and I'm going to try to get this right. It's hashtag CHCIHHM22. Okay, that's what it says on my paper, so go ahead and tweet. So welcome to all of you, and thank you so much for joining us. And so I want to ask you, as we kind of emerge and we're kind of in this state of flux, what's the number one thing on your mind as you think about defining what return to care means? And we'll start with you, Alicia, since you're right here.
First of all, thank you all for having me on this panel today. I'm excited to be speaking on this topic. I think what's really interesting, I think when we say the word return to care, we automatically assume that means that we're trying to go back to some prior status quo compared to where we are today. I think what's very important is for us to actually hopefully move forward from where we were before. And what I mean by that is I think we've learned a lot of lessons over the course of the last 2.5 years of this pandemic that we need to hang on to as we go back to in-person care. That includes thinking about how we do bring care to the patient where they are. I think prior to the pandemic, we were all very used to sort of bringing our bodies into the healthcare system to get our care. And what we learned during the pandemic is that we can actually bring that care to the patient where they're at. And that means things like drive-through COVID testing sites. We all got our vaccines in various mass vaccination sites or at our local pharmacies. And then definitely over the course of the pandemic, we've learned how to adopt and use telehealth services to help us with our basic prevention as well as urgent care needs. And I think these are all things we can hang on to as we think about moving forward into care post-pandemic. So that's, I think, what I would think about.
Great, thank you. So not just returning to the status quo, but really learning that lesson about bringing care to people where they are. Veronica, how about you?
No, thank you. And thank you, CACI, for the invitation. I was listening to Alicia, and I think all of us really took learnings from COVID-19. But even just one of the biggest things that keeps me up, in trying to figure out how do we move forward, but without forgetting the learnings from COVID-19. And especially when we talk about our Latino community. Our Latino community struggled during the COVID-19 pandemic. We learned and had a lot of learnings as to how do we really, truly deliver healthcare to our Latino community? How are we partnering with our community partners? And how are we building that trust? And one of the things that Genentech is really trying to do is how do we bring not only the care to where the patients are, but truly develop that trust with the community that we can understand and listen to the community. What are their needs? Truly, how can we be, as a industry, not only develop innovations, like what the first sponsor was talking about, but really take into consideration the needs that our Latino community has, which are very unique. When we talk about language barriers, we talk about access to care. And access, if you start unpacking, access comes in different shapes and forms. So one of the things to truly target equitable healthcare is we have to start thinking, how do we really, truly get to the Latino community by delivering not only in the language that they understand, be culturally sensitive, but also give them the access through many different programs that all of us should be thinking about. And how do we do that? So those are the different type of initiatives that I think in the Chief Diversity Office.
Great, thank you so much for that. And I think, it goes without saying, but as we talk about diversity, there's such a diversity within the Latino community as well. And so it's not just about this one-size-fits-all approach, right? I'm sure that's something you think about a lot.
Exactly, and even more so when you're talking, and I'm just gonna throw in another plug, and maybe Rich and Ahmed could expand more, is going back to your point as to not one size fits all, in talking about the importance of clinical trial representation. And we're gonna get into that more deeply as we have the conversation. But truly, I welcome Ahmed and Richard to expand more.
Sure. Great. Yeah, so Ahmed, what do you think? What does return to care look like to you and to Bayer? And then Richard, I'm curious to hear your thoughts.
Yeah, I'll say this, is at Bayer, we believe that health should be for all and hunger for none. Mm-hmm. And when Veronica mentions equity, I'll just ask the group a question here. How many of you guys are healthcare providers in the room? Raise your hand if you are. I think if you've been through COVID these last 3 years, the burnout in this has been tremendous for people who do frontline care. And the second question I'd ask is, how many of you know a patient or a friend or a family member that's on dialysis? Right, raise your hand. Almost everyone raises their hand. And what COVID has done, it's been a stress test for our patients. The sickest, the most confounded by healthcare comorbidities, they're the most disadvantaged. And when you put the two together, where you have burned out healthcare force, and you have the sickest of the sick patients needing the best care, what we saw for the first time was an increase in mortality rate in our dialysis patient population. And that's something that we've been striving for as a nephrology community for the last 25 years, to reduce the first-year mortality down below 20%. This 2 years has been a rise in mortality. And so what you can see is this equity piece, and now we're focusing on is that we realize that we have to be upstream, meaning that patients that are seen in the emergency room, they're not the primary care physicians. Those are emergency rooms. And the people that are the most disadvantaged should have access to innovative therapies and care. And I think that's what COVID is really teaching us in terms of point of care therapies at home.
Interesting. Thank you. We'll talk more about that. Richard, what about you?
Absolutely. First of all, thank you for having myself and Ahmed in this conversation. It's a pleasure and a privilege to be here. I would say the lessons that we take from the whole pandemic are strong in that if you take a research approach, and that is what I do, you would say this is the time to learn what we did on a massive scale, tackling problems that are massive to the nation, healthcare issues that affect our community. For example, the next one right below the line, diabetes in the Hispanic community, and then having bold action, wide dissemination of information, wide access to care, and take that approach for other areas. And then on a horizontal basis, take the issue from the very beginnings of research and clinical activity and clinical trials all the way to end-of-life care, and apply that model of tackling things boldly as we had done with the pandemic. We've taken many initiatives at Abbott to do that, and we can get into those later, but that whole renewed approach that includes a new and renewed approach to racial disparities as well. Let's face it, we went through that whole era in 2020 and beyond, where there was a new awareness of racial issues. Take that, combine it with a bold approach into medical care, and we have a great formula for learning and implementing going forward.
Great. Thank you. So I want to follow up on that, as we talk about a new approach, tackling problems more boldly, are there some examples that you've experienced? I think we were talking a little bit earlier about like innovations like pop-up clinics, getting people care where they needed, but like walk us down the path of what you see to be a bold new innovation that can actually start to tackle some of these massive public health challenges like diabetes or kidney disease.
Certainly, we can start in reverse this time.
Yeah.
Certain technology to bring care to patients pre and post procedural intervention, for example. There's ways to be with a patient that somehow, social media has figured out. You attach yourself to an individual and know everything about them. Why can't we do that with a medical care perspective? Plenty of opportunities there to follow the patients home and take care of them at home on a continuous basis and gather data that is actually relevant to their care on a continuous basis. And then there's artificial intelligence to be able to handle that, because a healthcare system will not be able to handle that massive amount of data. So that's one thing that we can. The other approach we have is, specifically in my job, is in clinical trials, is going to places we have never gone before to run clinical trials. Bring healthcare to the patient as opposed to have patients come to you when they have an event. And so we say, no, we need to enroll a lot more people of color in our trials. But they're in places, they're not 2 blocks from the Cleveland Clinic. They're in the barrio somewhere. We need to go there, find their practitioners, find their healthcare provider, even if they haven't been in healthcare before in terms of research. Facilitate that portion. It's not easy to send somebody to medical school and wait 8 years to recruit them to be in a clinical trial as a participant, but it's easy to teach them how to run a clinical trial. That's really easy. And so we can do that. We can do that and have an effect on the actual recruitment in clinical trials. So it's 2 examples on the 2 extremes of how we can have a bolder but different approach.
Great, thank you. Yeah, and I remember kind of early, I never followed the path of research, but spent a little bit of time contemplating that. And we talk a lot about bench to bedside, right? And it's like, but bench to bedside doesn't start like after the grand release of a drug, right? It should be much earlier, right? And so let's talk about that for a minute. I want to ask Veronica, and we can talk about this kind of more specifically in the context of representation in clinical trials. But you mentioned trust. I think that's something that has been a common theme here so far. I think we learned during the pandemic that like public health communication, messaging, trust in what was being shared was not, maybe the messages weren't all trustworthy or wasn't all uniform. So when you think about how you really listen, how you build trust, like what are some of the things that are working?
Yeah, and thank you for the question. And even just to, I think it's important just to add to what Richard was saying about clinical trials, taking those clinical trials to where the patients are. Typically we went to academic centers, right? Because that's where the expertise is. Now we're going to community sites, right? That's how you build trust, right? But not only going to the community centers, and I'll give you a specific example from Genentech. During the COVID-19 pandemic, our community, the Latino community, along with our Black communities, Native American communities, they were hit hard with COVID-19. When you looked at hospitals, you found patients of color who were dying, were being hospitalized at a faster rate. When we looked at COVID-19 induced pneumonia, that's where Genentech came in and said, we have a product, Actemra, that can actually be tested and see if it could help these patients. By going to the communities, building that trust. But how do you build that trust? We cannot just go and show up at a community. There are, people here in the audience, I'm sure you're from patient advocacy groups, you are the community leaders. That's where you start the engagement because it matters who delivers the message. It matters who is speaking to our community, who understands our abuelitas, who understands our moms, right? You understand because women at any culture that you go to, they're the ones driving healthcare. In less than a month, we enrolled 85% of 389 patients in our COVID-19 pneumonia study, and they were from patients of color. 50% were Latino, 12% were Black patients, and around 13% were of Native American descent. That showed us that if we truly knew how to engage and speak to our community, we could build that trust. And then talking about learnings, how do you not only stop there, but take those learnings to move forward? We did exactly that with multiple sclerosis. And again, we were able to enroll over 185 patients 2 months before what we thought we could enroll patients. But again, is not only engaging and building that trust, but even talking about what barriers do patients face. You talked about before, you have to go to that clinical trial site. But now let's talk about digital communication. We were able to leverage telehealth. We were able to do electronic consents. We were able to tell the patient, we'll come to where you are, meet you at your house, meet you at a local community center where we could take those tests that are not vital for you to come and require you to be at the test center. So that's how you start building that trust because you're telling the patients in the communities, we want you to be part of this trial and we're making it easy for you to participate.
Yeah, thank you. And I want to turn to digital because you all have mentioned it several times and ask you, Alicia, talk to me about what you see going forward. I mean, there was obviously a much greater adoption of digital telehealth. Zoom is now a verb. Like, we get that, sadly. But and there's some real policy conversations happening, you know, almost like as we speak, around flexibility is continuing and that sort of thing. But like, what has adoption looked like from your vantage point, and what digital tools do you see, whether it be telehealth or other kinds of digital AIs Rich was mentioning, you know, facilitating this effort going forward? Like, what's going to happen 10 years into the future?
Yeah, it's a great question. I think at the end of the day, a lot of folks, when they think about telehealth or digital medicine, they think that the entire workflow has to happen on the web. I think that's not the case. I think there's places for the use of digital tools to improve intake, to get patients their appointments, to make sure that people aren't frustrated by long wait lines and the inability to get access to provider. But I think at the end of the day, it does happen in parallel with in-person care. So at Color, we worked very hard on popping up many of the COVID-19 testing sites in San Francisco. At the height of the pandemic, we were responsible for 75% of all COVID-19 tests in the city of San Francisco, in partnership with the Department of Public Health there in San Francisco. And so we popped up these big drive-through testing sites, and we found that you wanted to make sure that folks could get easy access to those appointments so that when they did come through the drive-through site, it was very, very quick for them. You have to think about convenience. You don't want folks to have to spend hours and hours waiting in line or asking questions about, did I sign up for this correctly? You want folks to be able to get their questions answered and get the service that they need at the time that they need it. The other way that we thought about this was, as we were bringing testing to the communities, we also partnered with the Latino task force at the San Francisco Department of Public Health and actually popped up our testing sites throughout various communities in San Francisco, making sure that we were partnering with the local community leaders, working with our partners in the Latino task force to ensure that as patients were getting access to the testing, it's not 9 to 5, Monday through Friday, right? Folks have to get to work. You have to think about, can we have a site that's close to the subway station as people are going to or coming from work? Can we make sure that the hours are open outside of that 9 to 5 period, make sure that we have weekend availability, and then of course, making sure that we have culturally competent individuals who are working at those sites, who speak the language, who understand the questions that folks have. And at the end of the day, then the digital tool is really to help us ensure that we have people signed up correctly for their appointments, that we can get all the data and information, push that into public health reporting, and ensure then on the back end that we have good normalized data for folks. And then make sure then when you do have that in-person interaction with your healthcare provider, that you're getting the richest experience that you can there, because a lot of that upfront intake was taken care of through digital tools. You mentioned a bit about sort of what's happening with the delivery of telemedicine. I think it's actually interesting and useful to understand it's not just web-based medicine and video-based medicine. It's very important for communities to have phone-based access to care. A lot of folks are quite intimidated by having to go to a website or downloading an app in order to get access to a telehealth provider. You have to be able to think about how an individual can just pick up a phone, talk to a live person, and get their questions answered. And this is an area that we've seen quite a lot in COVID-19. When we first started our test to treat workflow with the Massachusetts Department of Public Health, it was entirely video-based. And then we added phone consults. We found that 60% of patients preferred to be on the phone rather than to go through that video consult. And so thinking about digital medicine doesn't always mean putting a physician on the internet. It's really about bringing care to the patient where they are. And that sometimes means you got to pick up the phone.
Yeah, thank you. And of course, you know, everything becomes a buzzword here in this town. So, you know, audio only telehealth is sort of like the thing, but appreciate that really tangible example. We're going to get to some audience questions, and you're okay. We're doing good on time. Excellent. But the room is starting to fill up, so we really want to get to your questions and sort of meet your learning goals. But I want to start, Alicia, by putting you on the spot again. Then I want to ask everybody here. I want to ask about sustainability, because you just described a couple of examples of like real sort of public-private partnerships and standing things up really quickly. I mean, I think we all know the world changed in like a minute, practically just within the course of a week. It was literally like the world had changed. And then a lot of things were stood up on an emergency basis. It was really unique in that it was something we were all experiencing, there's never been anything like it in our living memory. So how do you sustain that? What infrastructure is needed to sustain an effort where you can meet the expectations and needs of people and consumers and meet them where they are and figure out which metro stop they come up at or figure out, as we established earlier, we're not even all commuting anymore. How do you do it?
Yeah, it's a great question. I think at the end of the day, there's things that we started to work on during the pandemic that I think we can continue into the post-pandemic world. But as Veronica and Richard already mentioned, the partnerships, they have to be long-lasting. You can't just come to a community, pop up a tent and expect people to show up. You have to work on those relationships well in advance. You want to build that trust with that community. You want folks in the community to recognize and understand what is the service that you're trying to bring. And I think it's also about transparency about what you're going to do. We talked a little bit about clinical trial participation. At the end of the day, what's very important is to be transparent. What is my data going to be used for? What is the outcome of this trial? And how does my community benefit from my participation in this trial? I think we ask often too much of trial participants to just give of themselves without explaining to them about the downstream benefits that they can reap from participation in the trial. And I think as researchers now, we understand that we have to really show up. It's a two-way conversation. It's a two-way street. We have to bring something of value to the community in order to get them to participate in our trial. And I think that's where, as we think about outcomes of clinical trials, making sure that the outcomes are reported across all demographics, thinking through how we can leverage those existing partnerships, those long-standing partnerships with community leaders, with faith-based organizations, with healthcare providers within the communities, making sure that those things are happening rather than necessarily sort of popping in, doing a thing, and then popping out. At the end of the day, the community will trust the folks that are there every day. And I think that's something when it comes to sustainability, it's about maintaining those partnerships and those relationships, not only drawing on them when they're convenient. I think the other piece from an infrastructure standpoint is that we actually have a lot of the tools we need. We have the ability to do tele-based medicine, audio-based medicine. I think that there are policies that could come and affect the ability of patients to get access to audio-based care as CMS billing becomes part of that conversation as well. And I think there, from a sustainability standpoint, it's important for us to think about what are the things that the PHE allowed that we need to continue to have in place post-pandemic, especially when it comes to getting access to care, not in in-person settings, over the telephone, over telehealth. These things are going to be very important for sustainability as well.
Great, thank you. So I'm going to mix it up a little bit. Ahmed, what keeps you up at night when you think about sustainability and the health of people moving forward?
I think Richard made a good point, and he mentioned diabetes, and we focus in cardiovascular and diabetes. I mean, 9 out of 10 American males in the U.S. have metabolic syndrome. They're overweight. And when you look at the number of patients that just have diabetes and then have chronic kidney disease, as I mentioned, they're the most socioeconomic depressed. And so I spoke here maybe 3 or 4 weeks ago in DC for a policy summit. And one of the great things that's going out in the House legislature, and they're really talking about it, is about prior authorizations. And really the work it takes for physicians to give drugs to patients who need it at a timely manner, right? Sometimes when you go upstream, you need to find the patient that has risk, and then you have to be able to treat them with the right therapies that are innovative therapies at the right time. And so what I presented a few weeks ago, there was a really great, I don't know if anybody's here is from Texas. Anybody from Texas? And so Texas, so I really believe in public policy. And what Texas has done is they found that anybody that's seen in the emergency room that has diabetes, then get the standard of care medicines, and the state of Texas will pay for it. Because they realize what an epidemic diabetes is, right? That's forward-thinking policy. That's innovation. right? Putting right therapies at the right time for the right people who need it the most. How we move that forward is something that this group, and really that's one of the reasons I was excited about being here, how we can get people who are patients and voters and others to make a big difference in public policy.
Thanks. Richard, what about you?
Certainly, there's an element of having the technology that identifies the patients early at the right time. Having that technology is important. Having that technology accessible to patients and easy to use is a huge burden on our technical personnel. Ahmed has a sustainability plan where we have every product has to meet specific standards of access and affordability that have to do with ease of use and cost, naturally, and effectiveness of the product at detecting at the right time at the location where the patient is. So that's a huge element for us. On the broader social elements are, access to broadband, to be able to participate remotely. Not everybody lives next to a wonderful clinic. Having that access is important, and having the access to a broadband is a huge component of that. And then massive information, telling people how exactly is it that this disease affects them and where does it go in their terms, in their language, that is actually interpretable and actionable for them. So those are huge elements of sustaining this that are all technology involved. It's really all about the technology and facilitating that access where it is. Not the traditional centralized model of the immunochemistry being done in the basement of a hospital. It works for the hospital, it doesn't work for patients in their own neighborhood. So that needs to change, and we need to make technology do that for them.
Yeah, go ahead.
Could I make a comment?
Please.
It doesn't have to be complicated. It can be simple. Previously, I helped lead an international program, which was for acute kidney injury. And what we found out, let's say just in India, more people had a smartphone than they had a toilet, right? And so what Richard is saying is so meaningful. If you have, there's a book by Eric Topol, which is called The Patient Will See You Now. Mm-hmm. And then you see if the patient is in control of their health care, and I bet everybody in this room has a smartphone, then this ability to make it simple is really there. And I think, I sit in the MIT office of the Innovation Center in Cambridge, and I'm telling you, the new technology with quantum computing, predictive analytics, all these things, it will blow your mind. And so I'll ask one question to the group. How many of you use Google Maps, Apple Maps, or Waze? Now, keep your hand up if you know how it works. You know how it works? Like, you know the computer algorithms in the back. Nobody knows how it works. But listen, I mean, how many times do we drive and get to a place and say, I never knew this street existed, but we're there. We don't have to know how it works to get to the result that we want.
But let me just add to that, because we don't need to know how it works, but we have an idea of how to use the technology.
That's right.
We have an idea as to how to access the technology. And I think right now where we are is, how do we communicate that to our communities, right? I do not have the answer. I think that's a $1 million question that all of us are trying to figure out. What is the right way to engage our communities? But I just wanted to add something to what Richard was talking about, which was delivering that personalized healthcare to the patients, delivering the right treatment to the patient. And what can we do? We have a diverse group here. Us from industry, we cannot solve this. We cannot come with the solutions. It's going to take a village. It's going to take private corporations, patient advocacy groups, policy and legislators, a call for everyone who has the ear of a legislator, because it's going to take legislation. At Genentech, when we talk about personalized healthcare, one thing that we work very closely with the American Cancer Society is with biomarker testing. Biomarker testing is so important. We're going in a new era of where all of us are probably going to have our genome sequenced. All of us are probably going to have a smartphone, and we are going to go to the doctor and we're going to be able to say, download my genome. But however, not every state has biomarker testing that is approved and covered for. Not every payer covers biomarker testing. And who is going to be affected the most are communities of color.
That's right.
So those are the issues that we need to address. and really come up with innovative ways as to how we're going to address that.
Well, that definitely opens the mind to some imagination. Alicia, were you going to jump in? And then I have to ask about long COVID, because I feel like we can't talk about return to care without like asking you guys a question about what you see happening with that. And then we'll open it up to the audience. But Alicia, I want to make your final point on that.
Yeah, in terms of communicating with the public, I think one thing we have to also remember, I think people are very resilient and they want to know the information. I think all of us have learned what a PCR test is in the last 2.5 years, right? And we all learned the word mRNA at some point during vaccine rollout. I think at the end of the day, we have to remember that people will love to know the information. I think explaining and making sure it's not a black box and making sure that there is good scientific communication about what are in these drugs, what does this intervention mean, where is the data that backs why this drug should be useful to me. I think these are things that the public is hungry for and ready for and able to understand. It is about making sure that you're able to do that in a way that is in the native language that folks speak, that understands where people are coming from. But, I'm also a PI on the NIH's All of Us research program, and there we're recruiting 1 million participants across the United States. We're returning genetics results back. And we've started we're doing that by the end of this year, and really educating folks about what it is to get genetic results back and how that might affect their health. People actually are very hungry for that information. They want to know, and they're ready to know it. And so I think there is something very important when it comes to communication about making sure that we don't assume patients are not ready for that information, but rather how do we make that information accessible to them?
Okay, thank you for that point. So let me ask about long COVID. There's the physical effects of long COVID itself. There's obviously some health effects that come from just like the last few years of the pandemic. As Matt, you talked about mortality rates being higher. Like, what data are you going to be looking for? What information are you looking for to sort of parse out like what is happening with that? And how are your companies like looking into that? Are you addressing it? And what do you think the sort of prognosis is, if you will?
Yeah, it's extremely relevant. The CDC just put on their website publication from the household survey by Census Bureau that says 9% of Hispanics have long COVID. 9%. It's roughly 10 to 20% of the population who got COVID, and that already is estimated in the 70% range for the U.S., whether it was symptomatic or not. So it's highly prevalent, first of all. And I've seen publications already from meta-analysis and natural history studies that say that the incidence of cardiovascular disease in people that have contracted COVID, especially the early onset of the epidemic, the pandemic, and the early strains of the virus are very much affecting the cardiovascular system. So long-term, this is going to evolve into a higher incidence of many of these cardiovascular diseases and others as well. And we are keenly aware of that. It's a real problem, let's face it. It's a very real problem.
And it's not only cardiovascular, right? When we look at at cancer rates, what happened during COVID, with the shutdowns, all of us here are very well aware that most of us did not go out, right? And what was the first thing that dropped? Your medical appointments, right? And there is data, that shows that cancer rates are up. And this is even when we talk about breast cancer. Women did not go in for their mammograms. And we know that screening is important. We know that screening is the first step to a cancer diagnosis, and you need that diagnosis to get the right treatment and the right prognosis. So we are, that is something that at Genentech, being an oncology company, we are following very closely. We're partnering with the American Cancer Society as to how do we start increasing awareness campaigns. Do not skip your cancer screening. Go and get that breast mammogram. Go and get your colorectal screening, lung cancer, liver cancer, because that's where it starts.
On the long COVID side, I think one thing to remember here, and it goes back to where we started, which is about making sure we have diverse participation in clinical trials. Long COVID, we're still trying to understand how it affects populations and how it affects different individuals differently. There's actually a great NIH trial right now called Recover that is trying to study long COVID, and it's recruiting across the United States. And some of the areas where they're not getting as good uptake in recruitment is amongst the Latino community, getting Latino patients who have long COVID enrolled in that trial. And then the other portion of individuals that they have a hard time recruiting are people who have never had COVID, which is supposed to be the control arm. And so I think this, again, is where if we want to really understand long COVID and we want to understand how it affects all communities, this is going to be important, making sure that everyone is participating in those trials, in those studies, so that when the therapeutics come out, when the payer coverage for what your symptomatology looks like comes out, that's an accurate reflection of how long COVID affects all populations, not just the folks who opted into those specific trials.
And Alicia brings a great point, because that is something that all of us in this room could do, is how do we activate our own communities, even start with our own families. I could tell you, I go to my family and I'm like, have you heard of what a clinical trial is? Let's talk about a clinical trial. Sometimes they look at me like, you're so crazy, you're trying to, take us to a clinical trial. But that's the power of education. It has to start with educating our communities, because you're talking about the recovery study, and I'm like, I have not heard about that study, right? So that's another problem. How many times there's multiple studies, well-intentioned studies, but they're not publicly known. And one, it's not publicly known, and two, how do we even, to your point, Alicia, earlier, how do we even tell the patient how is their data being used? One thing that we started to do at Genentech is that at every study, at the end of it, when we have a study, we work with patient advocacy groups to develop a lay summary for patients, where we share that lay summary with patients and we tell them, this is what your data, looked like, this is the outcome. So then that patient is empowered and says, my data mattered, and it's going to be the next step. And if it doesn't help me, it's going to help my family, and it's going to help my community.
Yeah, thank you for that. It's a good reminder. Not all of us live in the DC metro area where there's literally NIH clinical trial posters on the subway, right? Yeah, that's great. I want to get to a couple of questions from the audience. There is a standing mic here, but if you are not able or comfortable to stand up, just go ahead and raise your hand, shout out your question. I see a lovely participant coming to the mic. Hey, thank you. Will you please state your name and your question?
Of course, the mic will be taller than me on the day I didn't wear my heels. Hello, everyone. Thank you for a great discussion today. Dr. Ines Ruiz-White, I'm R&D lead of DE&I at Otsuka Pharmaceuticals. And I wanted to talk to you today about, or I have a question regarding inclusion-exclusion criteria. So we talked a lot about the importance of diversity in clinical trials. I personally believe that. My company personally believes that. But we also talked about comorbidities that happen in higher prevalence with the underrepresented groups we are trying to enroll. And I wanted to get your feedback, thoughts, maybe even recommendations about, in your experience, how that has been able to overcome clinical trial designs that naturally exclude HIV patients, which might have higher rates, right, in underrepresented patients, exclude diabetes, BMIs over 40, right, kilograms. So I just wanted to get your thoughts, maybe some recommendations and what your companies have done or what you have read, and think about how study designs should be to overcome those inclusion-exclusion criteria.
Yeah, absolutely. There's hidden exclusion criteria in every trial. I can give you a few examples. For many of the clinics that we traditionally go to conduct the trials for us found it difficult to communicate with people that didn't speak English. It wasn't stipulated anywhere that you would have to include them or exclude them. And in fact, many times, like in Texas and California and Florida, we offer services where within 5 minutes you have somebody with a medical interpreter on the other end to conduct all follow-up visits. But clinics are not aware that those are services that are readily available and don't put it in their budget. So de facto, they are excluding Hispanics from their trials of older ages because they don't speak English and it's difficult to follow them. That's one example. Another example is people assume that they should not be enrolling people who are not legal in the United States. Horrible term. And so therefore, by de facto, anybody who cannot present evidence of residency is not included because they don't know when they're going to go back to their country or if they're going to be found somewhere or arrested somehow. Horrible, right? Horrible situation. So he said, no. The medical care is paid for by the trial. And whatever way we can cover the follow-ups, we will cover the follow-ups. You enroll a human being, period. Write down what ethnicity, what race, and everything else, and we'll take it from there. But you have to actively communicate with these clinics to let them know all these things are possible. Otherwise, they will not. They'll assume, and that's the worst form of bias when it's just a hidden bias, right?
And one follow-up on that, Lisa Thompson, who's the deputy director of the FDA, wrote a really nice paper in real-world evidence and pragmatic trials. And I think what's a challenge for a company is the regulatory hurdles for efficacy are based on endpoints. In real world, and I'm a big proponent of Rob Califf, who's the FDA chair, formerly at Duke and Verily and all this, and he really says we need to get medicines approved faster, and then we need to follow them in a coordinated registry network. So I'll give props to CMS and CMMI, who are really trying to get these prospective registry networks so you can get drugs approved to all comers and then see the safety signal. Because the primary purpose of the FDA is safety, right? The primary purpose of us as industry is to get our drugs approved, right? And so we could have trillions of data banks of CRFs, but we're only trying to get one endpoint, the primary endpoint, right? And so this discussion really has to happen where the people that need the drug without exclusion criteria are the ones we want to follow, right? So we're big advocates of that.
But even if you look at the recent FDA draft guidance, right, for diverse clinical trials, there's a section that talks about look at the incidence rates, look at the epidemiology of the population that you're studying, and that is something that industry, and I'm sure your company as well, is trying to figure out, how, and it's not like when we talk about inclusion and exclusion criteria, we're not saying we're going to make our studies less safe, we're going to decrease the, compromise the study design, but we're really, in the FDA, in their draft guidance, is really asking us to rethink how we are evaluating incidence rates and epidemiology in the studies that we're trying to address, because comorbidities are usually a big factor that exclude patients of color. Right? And we really have to rethink that. And one thing that is, that I'm very proud that we're doing at Genentech, we actually have a diversity and inclusion external council. And this is prominent oncologists, ophthalmologists, neurologists, and patient advocates, are part of this external council. They advise us, when we come to them, we share our inclusion and exclusion criteria, and they help us really think how, let's not compromise safety and of course the study design, but what can we do? What do we have to do? Because all of us are responsible to really evaluate especially those exclusion criteria in order to make sure that our trials are truly going to be representative and include those patients that need and are most in need of the medications that we are innovating.
And Alicia, I'm sorry to cut you off on this. That's such a great question, Dr. Ruiz, but I wanted to mention that Representative Horsford is here, and we're having a great discussion. Thank you for your questions. Terrific. Thank you all for your expert answers. Representative Horsford, hi. Sarah Dash.
How are you?
Nice to meet you. Good morning.
Well, good morning, everyone. Thank you. I'm Congressman Stephen Horsford. I'm proud to represent Nevada's 4th Congressional District, and I know you all have been having an incredible panel discussion, and I'm sorry I couldn't be here for the start of the panel, but I know that this panel has been able to delve into a number of important issues around the state of healthcare in our community, what we've learned from COVID-19 pandemic, and what are some of the steps forward. And we need your expertise and your insights. I'm currently a member of the House Budget Committee, the House Ways and Means Committee, the Subcommittee on Healthcare, as well as the Armed Services Committee. And as first Vice Chairman of the Congressional Black Caucus, I have worked on several of our key emergency legislative responses to the COVID pandemic. But I think what is so clear from the beginning of this public health crisis was the disproportionate impact on the health crisis on communities of color, particularly Black and brown women. And as mothers, they could not work, having to care for their children at home. As daughters, they were struggling with protecting the elderly in their family while making sure those loved ones weren't isolated. As workers, they could no longer work because of their industries such as hospitality, education, travel, restaurants. We're seeing work stoppages or slowdowns. But yet as healthcare workers, they were working overtime and often staying away from their loved ones in order to protect them from a virus we were still just learning about. As home healthcare workers, they were struggling to care for the elderly while navigating health protections and precautions and social distancing guidelines. And overall, throughout the community, we saw impacts on healthcare, particularly people missing their necessary care and visits for known illnesses, and many more missing preventative screenings vital to saving their life. So now we are on a journey as a community to get back on track and improve where we were before the pandemic struck. But let us be clear, health inequities existed before the pandemic, and again, disproportionately affected communities of color. Imagine if we could harness a strategy where we use mass education and awareness to prevent key strategies around diabetes, heart health, kidney disease, breast cancer, and other ailments that afflict people of color. And we must take action on improving clinical trials and making sure our communities are included, all of our communities. We've seen that there are great differences in how some medicines and treatments work in different populations, so diversity and inclusion in our clinical trials is vital to successful deployment of therapeutics. So overall, there's a lot of work ahead of us. But together, I know that we will all be working hard to improve healthcare access for our community and to get people back on track to preventative care. And again, I want to thank all of you for being a part of this very important discussion. I have a number of team members who are here that I want to just give a shout out to. Miguel Ayala, who is my communications director. He was a CHC Institute fellow and intern back in the day. And Josie Villanueva, who was my former deputy chief of staff, also started as a CHC Institute intern and fellow. And both have gone on to do great things. And they are trusted advisors to me and our office and our team in trying to make meaningful impact. And I'll just close by saying, the disproportionate impact on communities around healthcare, around the economy, around housing and access to childcare, these are the social determinants of health that are really going to be critical for how we move forward. The Ways and Means Committee established a racial equity initiative working group. Jimmy Gomez, Terry Sewell, and I are the 3 co-chairs, and we are identifying specific federal policy that are beginning to be enacted, and we need your further recommendations, and I believe some coming out of today's panel that will help inform the work that we do going forward. So thank you to the CHCI and to all of you for today's panel and for allowing me to come and participate. Thank you.
Thank you so much. Thank you. Thank you so much, Representative Horsford, for really that clarion call to action. I think laying the groundwork for what we've been talking about. And, it does get down to the details of inclusion and exclusion criteria and what people think about someone who's in front of them in the enrollment process. So sadly, our time is up, but I want to give everyone at least just one last word. One of the threads that I think has really come through this whole panel is communication and the need for better communication, both broadly writ large, as well as just down to that nitty gritty of no, it's okay to enroll someone. So we'll just go down the line really quickly. What is the one thing, Alicia, that you hope people here in the room take away, and if they're watching the video later, what's the one thing you really hope they take away from this?
Yeah, I think at the end of the day, especially for folks in the room today, I think it's really important to have your partnership. And as you think about sort of what is the influence you have on your communities, how you can help communicate the work that we're doing in the industry around clinical trials, around drug development, around access to care and access to treatment, we do need that partnership with you all and also with the communities to ensure that folks understand what the importance of participating in trials is, what the outcomes of that can mean for them, and also how to help us bridge that last mile of care. So really making sure that the work that we're doing can actually get into the hands of the patients who need it most. And really appreciate everyone's participation here today, and hope that you take that away as something that we can all embrace as a call to action to really think about how we bridge to those communities that need the care the most.
Thank you.
If there's one thing that I want people to leave here with today, is that all of us can make the difference in increasing Latino representation in clinical trials. We need to activate our Latino community to participate, because at the end of the day, 85% of our clinical trials are of white descent. We have white patients. When we have decisions that are being made as to who gets coverage, who has access to the medications, those clinical trials are taken into account. And if we do not have our Latino community represented, guess what? You're not going to have access to those medications that our community needs. And I heard in LULAC, from one of the panels that I was on, that clinical trial representation is like voting. If you do not vote, you're not counted. If you do not participate in a clinical trial, we as a Latino community are not going to be counted. So please talk to your families, your friends, your partners, and let's get our Latino community activated for clinical trials.
I'll just say that you all can make a difference. Impact is here. And the two things we need to do are educate and empower ourselves and the people that we work for and with.
Absolutely. We cannot go back. We have to retain the lessons we learned from this pandemic. We have to institutionalize and proceduralize these newfound approaches to clinical trials. Abbott is committed to this because it's part of our sustainability. We will not get anywhere in 30 years if we don't take forcible action in this matter. And let's just go forward, make it a practice, embrace the guidelines, embrace the conversation, get our communities involved. It's important.
Thank you so much. Well, give yourselves and our panelists a round of applause. Thank you. Thank you so much.